from Aminu Nutrition Hospital. I'm going to present about rabies today. It's going to be on the following outline. So now, by introduction, rabies is a zoonosis and among the neglected tropical diseases. It's caused by a virus, and it has been described throughout documented history. That means it's a very old disease, but it's invariably fatal once symptoms begins. It has worldwide distribution with widespread geographic disparity, affecting all ages and gender. But certain occupations and habits are known to be more predisposing to this condition. The World Health Organization estimated about 35 to 50,000 deaths annually from rabies, and 95% of this occurred in Africa and Asia, with about $8 billion lost economically to rabies and costing about $100 per patient for each post-exposure prophylaxis. And about 10 million of these prophylaxis are offered annually. Virology. This virus is a bullet-shaped, enveloped, single-stranded, negative-sense RNA virus that belongs to the Rhabdoviridae family and Lissa virus genus, about 10 serotypes, notably including classic rabies virus, Mokola virus, Cotoncan virus, European Lissa virus, and Australian Lissa virus. In fact, I was even thinking, does it have any relation with Nigeria, looking at Mokola and Cotoncan in Kogi State? But that's just by the way. This virus is highly neurotropic with a nuclear capsid that contains the negri bodies. It has a long incubation period, about 90 days, and easily inactivated by physical and chemical agents, as it is with most enveloped viruses. This virus has many reservoirs depending on the region of the world. In Europe, you have foxes and bats. Middle East, you have wolves and dogs. In Asia, you have dogs. In Africa, you have dogs and antelopes. North America, you have foxes, raccoons, and in South America, you have dogs and vampire bats. So all these are possible reservoirs for this virus. Pathogenesis. This virus gets transmitted to susceptible hosts via saliva and excretions from the bite of an infected animal. Usually the reservoirs, whether the dogs, the antelopes, the bats, and what have you. So when this virus gets into human, it enters the peripheral nerves. And then, like we mentioned, it has a very prolonged incubation period from 9 days to 90 days. But during this period, there's active multiplication of this virus so that it becomes so enormous that it will spill the nuclear capsid into the myoneural junction. And at this point, the patient becomes symptomatic and the disease becomes invariably fatal. But from the beginning of the bite to just before the spillage, something can be done to salvage the situation. But once there's spillage into the nervous system, it's invariably fatal. And there's eventual retrograde movement into the CNS, beginning with the spinal cord and eventually into the brain. And then once it gets to the brain, then continual multiplication and then antegrade movement into the periphery, especially salivary glands for onward transmission to other susceptible hosts, as well as lungs, kidney, and other organs where it produces the symptomatology to the patient. But throughout this, there's no significant inflammation or neuronal damage. And this virus actually acts through blockage of neurotransmitters. The GABA, glycine, and acetylcholine receptors in the central nervous systems are blocked by this virus, and all the manifestations actually are because of this neurotoxicity, not cellular damage. And typically, viremia does not occur in rabies. Clinical presentation, very varied, from history. You talk about identifying risk factors, whether interaction with an animal, the behavior of the animal, because it's known that some animals, when they don't have to be actually aggressive. Even some dull and looking very maybe nocturnal animals like birds appearing in the daytime. All these are unusual behaviors that may suggest that the animal is having rabies. Then the vaccine status of the animals, as well as availability of the animal for testing when they present clinically. Incubation period from 20 days to 90 days. And it has excellent immune evasion mechanism. That's why it could live this long enough without mounting any response from the body. Prodromal period lasting for 2 to 10 days with non-specific symptoms, malaria, fever, cough, malaria, and the rest. But when it began in the acute neurologic period, the lasting 2 to 7 days, the patient has neurologic deficits, which can be either local or global. Then 2/3 of the patient will develop furious rabies, while 1/3 will develop paralytic rabies. And they may develop coma within 10 days from the onset of the symptoms. Neurologic period, the furious rabies, typically they are aggressive, they have hydrophobia, aerophobia, and they have a lot of autonomic instability, sweating, tachycardia, and the rest. While the paralytic rabies, they come with symmetrical or ascending paralysis with or without fever and nuchal rigidity. And once these symptoms, signs appear, coma will ensue within 1 week. And eventually they die from complications. Diagnosis of rabies is largely clinical because serology has limited utility. And then brain imaging, because we mentioned that there's no actual neuronal damage, so even imaging only shows non-specific enhancements on T2 weighted imaging. But viral PCR and culture from saliva, CSF, and brain tissue can be diagnostic. Serologies, including rapid fluorescent focus inhibition test, which can be positive into up to 50% of cases in the serum and about 5% within CSF. Nuchal skin biopsy for viral PCR is also very useful. Ultimately, histology, especially the brain tissue, will show cerebral congestion from inflammation, but no neuronal damage is seen. And the typical negri bodies can be seen on large microscopy in up to 70% of cases. And then when electron microscopy is done on this specimen, the bullet shape of the virus can be seen clearly. Differentials of this condition are many. Infectious diseases like herpes simplex virus, GBS, tetanus, botulism, traumas, myelitis, psychosis, ICSOL, epilepsy. All these are conditions that may present or mimic rabies. So management of rabies, there is so-called pre-exposure prophylaxis or immunization. This is offered to individuals who are at increased risk of getting infected with rabies. Those who are in very close contact with animals, including veterinarians, hunters, people who work in the zoos, and then healthcare workers, especially laboratory staff, because they get contact with these samples that they have no idea where they come from. So it's typically given at the dose as a vaccine, the human diphtheria cell vaccine, a dose of 1 ml intramuscularly at day 0, 7, and 28. Then there's a booster dose to follow up after 1 month. Then another booster dose every 3 to 5 years. So this is typically what is offered to these patients, people who are at risk of getting rabies infection. Then when eventually a patient develops rabies, so the treatment can come in 3 stages. First aid, the post-exposure prophylaxis before onset of symptoms, and then the eventual medical treatment after onset of symptoms. So you can give first aid, then before symptoms appear, and then what you do when there are symptoms present in the patient. As for first aid, there should be thorough cleaning of the wound with soap and water for about 10 minutes, 10 to 15 minutes. You wash thoroughly, you debride the wound. Depending on the nature of the wound, you debride and explore carefully for any remnants of the teeth or any foreign body within the wound so that you can promote proper wound healing. And then it's advised that you should avoid primary closure of the wound so that any discharge, anything can be easily cleaned or drained during subsequent dressings. For those who are yet to develop symptoms, that means they are still within the incubation period, you can give them both passive and active immunization. The passive immunization is meant to give protection for at least 1 to 2 weeks before the body elicits or develops proper antibodies to cater for the rabies virus. And this is given as human rabies immunoglobulin at a dose of 20 international units per kg, which is to be infiltrated around the wound as much as possible. All the dose should be given around the wound where the patient got bitten by the animal. So if the volume is so much that cannot be given, then after infiltration around the wound, the remnants can be given intramuscularly elsewhere in the body, but not where the active vaccine is given to the patient. This active vaccine is given at a dose at 2 intradermal sites at a dose of 0.1 ml, on days 0, 3, and 7. Or you can give this vaccine at 1 site IM, on the 0, 3, 7, and a fourth dose to be given anytime between day 14 and day 28. Or the last option is to give this vaccine at IM, two-site vaccine on day 0 and one-site IM on day 7 and 21. So this is to ensure that the patient get both passive immunization protection and then you give active immunization so that the patient can develop antibodies that will subsequently cater for any rabies virus within the system. So this study that shows that they are actually support the use of this 4-site intradermal regimen for rabies vaccination. And this is a table that shows all the various regimen and how they are given, number of days, and the total vaccine required. It's a table that we can go through at a free time.
Okay,
This is
Chief,
the initial study there with abstract. Medical treatment after symptom onset. So when the patient eventually develops symptoms, so you have to treat the patient. But unfortunately, it's very ineffective because we know that there's defective humoral immunity in the CNS. Antibodies are not really effective there, so they cannot neutralize or mop up the virus. And then animal data support the use of human monoclonal antibodies, which can be given both IM and CSF, but still it's not found to be effective. Serious use shows increased mortality in animal studies, and therefore, because of this fear, it was not even tried in humans. And then eventually, all that you do for the patient is supportive care. Manage temperature, tachycardia, other symptoms, especially embarrassment, you support respiration and other things. But all of these are symptomatic because eventually the patient will invariably succumb to this lethal condition. Challenges to rabies management include this is a very rare condition with few chances of learning. We know that the more cases you see, the more you will learn new things and then the more you improve your interventions. But these cases are very few. They occur sporadically. So there's no enough experience or exposure so that people can have real life or real world experience managing these conditions. Again, because of the lethality of this condition, there are a lot of ethical issues surrounding conducting clinical trials because you can't imagine trying to give somebody standard of care or what you do now, and then you offer somebody something you know that you are not sure of the validity or usefulness of that intervention. So ethical issues preclude conducting clinical trials on rabies. And then the high cost of care, we mentioned about $100 required for each post-exposure prophylaxis. That is quite high. And then there's still limited donor partnership. We mentioned that it's a neglected diseases, and that's why not much donors are interested in donating money for research and treatment of this condition. Prognosis. This condition is vaccine preventable. That means it's excellent if you can get vaccinated, especially for those who are at risk. However, for those who get infected, it still remains very poor, despite aggressive and intensive care once the patient becomes symptomatic, and disease is invariably fatal. However, you know, they say never say never in medicine. There's a story of one patient who survived rabies in Wisconsin, US, in 2004. They call it the medical mystery. Only one person has survived rabies without vaccine. But how? This patient, when she got bitten by the animal, by a bat actually, she didn't sought for medical attention. There was no any prophylaxis given to her. Eventually, she developed symptoms, and then clinical evaluation and subsequent tests confirmed she had rabies. She was taken to ICU. You know, they supported her breathing, they blocked her brain so that and they tried some antiviral agents and supported care. And eventually, after 6 days in coma, she miraculously regained her consciousness, and she eventually survived and was discharged. And 20 years later, she was still active and then working and living her life. But like I said, this is the only one that's reported so far, and many people who have rabies actually die from it. So prevention, like I mentioned, community education, people should know about this so they can get protected, and then they know how to handle animals properly. And when they get bitten, they should seek for medical attention as early as possible so that they can be given prophylaxis before symptoms develop. For healthcare workers, infection prevention control measures, universal safety, universal precaution so that you don't get exposed to this fluids and secretions unnecessarily. Pre-transplantation screening. It's known that there are some cases reported to have been transplanted from corneal transplant. So there's a need to screen patients or donors before transplantation is conducted. Health system strengthening and immunization so that people can get vaccinated, when they need it, when they require it. Primary prevention at the level of zoonosis. So these animals need to be actually taken care of and then they should be vaccinated to prevent them from harboring this virus and eventually transmit it to individuals. And that's why the concept of One Health approach, knowing that this is a virus that is primarily residing or reserved in animals, but eventually can spill and infect humans, causing all the problems. So, and this is an issue of One Health approach, the intersection between the human, animal, and environmental health is very important in addressing rabies as a condition. So in conclusion, rabies is a fatal zoonosis and a neglected tropical disease. Cases still occur, especially in developing countries. It's vaccine preventable, and there's effective prophylaxis for early presentation. Very important, early presentation before symptoms appear. But it's invariably fatal once the patient becomes symptomatic. Thank you for listening. These are some of my references. Thank you.
Wow, thank you so much, Dr. Damsada, for that beautiful lecture, professorial lecture. Thank you so much. Okay, so we'll take comments and questions from the participants first, and let's keep the thanks coming on the chat. Thank you so much. Okay, Chief, let me just ask first. So are you saying that even when the patient becomes symptomatic, even the immunoglobulin doesn't help?
Yes, it doesn't actually. Once they are symptomatic, nothing works. The immunoglobulins are meant to work before they become symptomatic. If you look at the pathogenesis of the virus, so once the virus gets into the peripheral nerves, it goes in a very quiescent manner multiplying. So it's at that period when they are multiplying before they get to the spinal cord and eventually the brain that you can give them immunoglobulins to trap and mob them at that level. But once they get to CNS, they begin to spread antigradually into other tissues, and then from there you cannot do anything about it. So it has to be before symptoms appear. And the symptoms appear once the virus gets to spinal cord.
Thank you so much. Okay, so a lot of applause for you on the chat. Everyone is applauding your beautiful presentation. Dr. Alozi says thanks. Dr. Araga, Dr. Yahaya, Dr. Temitope, Dr. Blessing Azukoyamadi, they're all applauding you for the beautiful presentation. Dr. Mamodu dropped a picture of the chat. Mokola virus was first isolated from the Procedura shoes. Okay, it looks like a rat. In the Mokola Forest, Ibadan, Oyo State, Nigeria. Okay, Chief, that's what you were talking about.
Yeah,
okay.
So thank you for that. I don't know why I said that this Mokola and Cotton Carfe, I said, oh, this and then Lisa. I know Lassa virus in 1960 in Borno, but this is the Lisa virus. So thank you for that, Dr. Mamodu. Thank you.
Okay,
hello, can you hear me? Sorry.
Yes, I can.
Hello. Mokola virus were there were bats in caves in Mokola. There used to be caves in Mokola. So It was from the bats in the caves. You find it in old Harrison textbooks. They don't discuss it, they don't write it anymore. But they say it was from from bats in caves in Mokola virus. I think the bats used to bite people around, and then they'll present with rabies.
Okay, thank you so much.
All right, thank you so much, Dr. Fion, for that input. Thank you so much. Okay, so let's continue on the chat. So Dr. Dr. Ede Ifoma is thanking you. Thank you, Chief. Dr. Olaito Abimbola is saying thanks for the lucid presentation. Mongoose and cats are also reservoirs. Risk and severity depends on size of inoculum, multiple bites, bites on direct skin, not through clothing, and bites close to the face. Okay, so I think those are kind of poor prognostic factors. Then furious rabies also has autonomic dysfunction, pupillary dilatation, salivation, and priapism. So irrigates the wound with iodine after washing with soap and water because it is virucidal. Did you come across the Milwaukee Protocol? Thank you, Dr. Lighton, for comments. So, Chief, she's asking you.
Okay. Well, no, not really. But I appreciate all the other contributions. They are part of it, actually. All the things you mentioned are very valuable. But the protocol, not yet, please. But I'll look for it. Thank you.
Okay. Chief, thank you so much. Can you add to your slides before you send it?
Yeah, surely, I'll do that.
All right, thank you so much. Okay, so Dr. Yahaya is saying thank you so much, Dr. DSD, for the lucid presentation. Dr. Shamsuddin Abdullah says thank you. Does that mean post-exposure prophylaxis prevents the victim from developing symptoms?
Yes, yes, that's what it does. It blocks the progression because, like I told you, is once the virus gets to spinal cord, then symptoms begin to appear. So if you can block it before getting there, then there will be no symptomatic presentation, and the patient will get better while he develops his own antibodies from the vaccine you gave him, active vaccine you gave him.
All right, thank you so much.
Oh.
Dr. Adekunle says thanks for the presentation. Dr. Mamodo is adding, rabies has the highest case fatality of any human infectious disease. Thank you so much, Dr. Mamodo.
Yeah.
Is the myth that if the dog dies, the dog likely is rabid? Okay.
Yeah, actually,
Dr.
a lot of myths about rabies. You know, actually, a lot of people assume that a rabid dog must be aggressive. And okay, a rabid animal has to be aggressive, but it's not true. In fact, it says they can be all the extremes. They can be aggressive and they can be so indolent. In fact, they say if you see a dog or a rabid, an animal that's a reservoir for rabies, unusually quiet, so that's even another sign that they could be rabid. Or you see a bird that's meant to be active at night, now only appearing in the daytime. So that's also a sign that that bird is actually rabid. So, but once animals become symptomatic, they die within 10 days. That one is established. And that's why once the patient is bitten, and then you bring the animal and quarantine the animal. So if the animal didn't die within 10 days, so it's likely to be rabid. But once the animal survives beyond 10 days, so then likely rabies is out of it. But you get the animal, you can either do euthanasia, kill the animal, get the tissues, and go and confirm the presence of rabies or not. And if you cannot kill the animal, then you keep it in one place and keep observing it. If it's rabid, within 10 days, the animal will die. All animals with rabies, once they become symptomatic, in 10 days they die. So that has been documented. But for individuals, it depends. Incubation period from 9 to 90 days, and then when they become symptomatic, depending on the compromise of their systems and their reserve before the incident. So it depends on how long they live. Thank you.
Thank you so much. Okay, so Dr. Christian Adayi says thanks for an excellent presentation. Dr. Paul Ewanta says thanks a lot for the lucid presentation. Dr. Layeton is adding, Milwaukee protocol involves induction of coma with ketamine, midazolam, or use of high-dose ribavirin and amantadine without use of vaccine or immunoglobulin.
Okay, so thank you for this. Actually, this is what was used for the survival in Wisconsin, and from all the literature now, that this is not recommended. Actually, it's not recommended at all. So all the observation that was done, but actually now most of the literature they don't recommend any of this because subsequent studies have not shown them to be really effective in treating this.
All right, thank you so much. Okay. Okay, please add it to the slide too. And then Dr. Onelum says thanks. Which tissue is used for the histology you mentioned?
Yeah, it's brain tissue. Brain tissue. So when they take the brain tissue, sorry? When they take the brain tissue of the patient or the animal and they do histology, there is congestion, and then there are these cytoplasmic inclusion bodies that are called the Negri bodies. So they're actually the nuclear capsule of the virus with some eosinophilic changes as cells around them. So that's what form the Negri bodies in the cytoplasm. So there are cytoplasmic inclusion bodies in the neuronal cells of either the animal or the victim who died without any neuronal damage, particularly.
All right. I want to assume that the human histology is done at postmortem.
Sorry?
I mean, you said brain tissue for humans.
Yeah. At autopsy. It's at autopsy, actually. It's at autopsy.
Okay. Okay, thank you.
But for diagnosis, they use skin. They use skin of the nuchal, the neck skin. That's what they use for diagnosis if the patient is still alive. So they take skin from the neck, and then they do histology. They do PCR. Now it's not histology, it's PCR for the viral RNA. So, but the histology is for after death. Then they do autopsy. Then they look for those inclusion bodies. Histology.
Okay. Okay. So the next, that's why. Okay, you get your sample from there. All right.
Yes.
Okay. So others are also making a comment on the Milwaukee protocol. Thank you, Dr. Blessing. chemically induced coma. Yeah, Dr. Mohammed is also adding therapeutic coma. Dr. Adiboke says, thanks, excellent presentation. Dr. Mohammed is asking, okay, adding therapies to avoid. Okay, so you should avoid these drugs in a rabies patient, minocycline, corticosteroids.
Yeah, in fact, I mentioned it. Studies have shown that use of corticosteroids in animals increases mortality, and even in humans, because you know when you give vaccines and then you're giving steroids, so you are counteracting your intervention. You are giving vaccines and you're giving steroids, so steroid will depress the vaccine and then prevent uptake and then eventual response by the patient. So steroids have been shown to worsen prognosis and increase mortality in patients who have rabies.
All right, thank you. So Dr. Olaiton is adding direct fluorescent antibody staining of skin biopsy taken from the nape of the neck because the virus is localized in the hair follicles. Thank you, Dr. Olaiton. Dr. Regina Wiki says, thanks for the excellent presentation. Wow, it's really been a very beautiful, thought-provoking one. Thank you so much, Dr. Dansada.
Thank you so much.
Let me see if we hands. Okay, if we have any hands. Okay, Dr. Sani's hand is up. Dr. Sani, please go ahead.
Thank you very much,
Hello, sir.
Chief, for that beautiful presentation. Actually, it was a professorial one, as Chief mentioned. Just few clarification and addition that we should take away from rabies. That apart from even from the post-exposure prophylaxis, emphasis should be paid on the pre-exposure prophylaxis. Very important, especially in people at risk. People that involve in dogs, cats, those that go for exploration, those that usually go for hunting. The pre-exposure is virtually more important even in their case than post-exposure. Then early things, because rabies, the major problem with rabies, don't allow the symptoms to develop. You still have a window for the incubation period. Actually, usually for the retrograde transmission, usually for the virus, usually take around 7 to 10 days or less than that. So you have a window of 1 week to do the right thing, and as he rightly mentioned. So that one is very important. Then I wanted to mention the Milwaukee, but I think he has already addressed it. It's a controversial and it's something that is not even need to be mentioned. It has been done before with virtually no success, because you are inducing a patient into a coma, and it has been found to be ethically a bit dilemma, because most of the time patient and patient relative are curious or are anxious about losing their relative, so they likely sign the consent. But the outcome has been very poor, and virtually I think only one survival before. And then lastly, the issue of what needs to be done immediately before the rabies. But I know in our area, the major challenge now is even getting the immunoglobulin. Most of the hospitals around us don't even have the immunoglobulin.
Translation. Kindly listen text, please. Please.
So the major problem is the immunoglobulin that is not readily available, and then the costs. Even the rabies vaccine, there are usually a lot of counterfeit in the market. So the major challenge is, what do you need to do if you get a dog bite? The dog bite, definitely we don't even report them to the veterinary clinics. We don't even report the case to police. We don't even take action from the dog owners and the rest. So as he mentioned, the One Health approach is very important. That's why whenever you are asked about rabies, you can't discuss rabies without, it's one of the cornerstone of the One Health approach. We have to bring everybody on board to ensure that it doesn't cause unwanted damage. So what you need to do is thorough cleaning of that wound site. Very important for you to do thorough cleaning of that site, the immediate reporting to the hospital, and probably reporting of the dog to the relevant authorities for the further action. Usually dogs are killed. The biopsy initially is, once the dog start to have symptoms, the dog should be killed immediately. That's the target. But there are a lot of problems now with animals, animal rights, issues of cases. So because you need that biopsy from the brain of the dog for you to even discuss what do you need to do. But there are a lot of issues with losing the dog, killing it, and the rest. Yeah, so it's always a big dilemma to deal with. So I think those are my few additions to but overall, it's a very good presentation. Thank you very much.
Well, thank you so much, Dr. Sani, for that beautiful add-on. Sorry, Dr. Sani, please let me just ask, just in case you have a patient that comes and says, I was bitten by a dog, is it okay to go ahead and give the immunoglobulin and the vaccines, whether the dog is rabid or not?
The problem there is, first, the first thing you need to do is to even assess where is the dog. Is it a stray dog or is domesticated dog? Most of the time, people that usually keep their dogs, usually those that are in well-to-do areas, but they usually vaccinate their dogs. So first, you have to get where is the dog, who owns the dog, has he been vaccinated? That should be the first step. If the dog has been vaccinated and dressed, what we are encouraged to do is to follow the protocol. And what the protocol encourage is usually look at your patient, look at the dog. If there's need, you can give your immunoglobulin and the vaccine. You're not losing anything. But the protocol says if the dog is vaccinated and he is not symptomatic, you don't need to. But if you're not sure and you don't want to take a chance, and this one is discussion between you and the patient, go ahead and offer your vaccine and immunoglobulin. It doesn't take anything away, especially if the patient has not been vaccinated in the past. If he has not been vaccinated, then it's an avenue for you to vaccinate him and prevent him for the future while you give your immunoglobulin to mop up the antigens. If accidentally they're deposited into the muzzle, then you complete the vaccine. Because even the regimen, the 5-dose regimen has been revised. The IM, there are a lot of revision now. Can we continue with because the subcutaneous administration now can be narrowed to 3 doses rather than the 5 doses that's used to be, especially for the unvaccinated. For those that are repeat bite after a rabbit bite, then you can add booster 2 doses. So there's nothing wrong in administering, but the protocol says otherwise, because we are still adopting the Western and the developed protocols.
All right, thank you so much. Okay, so Dr. Rita says thanks. Dr. Mamodu is adding, brain hypothermia has shown effectiveness as a neuroprotective therapy. Thank you so much, Dr. Mamodu. Okay, so at this point,
let me come here. The problem with rabies, most of the interventions and all those they are virtually counterproductive. As I mentioned to you, once the virus reaches the central nervous system, Dr. Anson mentioned it's a mistake. It's only a miracle that will save the patient. So most of those approaches, maybe they may add hours or a few days into life. The issue is the symptom. It should be proactive for symptoms not to develop. In short, what was mentioned is once there is paresthesia or numbness at the site of bite, then death is inevitable, because the nerves have already taken up through the vesicles. So the target is no symptoms. Proactive to prevent is the key. Pre-exposure, post-exposure would prompt intervention. That is what is advocated. But most of those interventions it's something that we don't even offer here. They are not even available in our facilities. Thank you very much.
All right, thank you so much, Dr. Sani. Thank you so much, Dr. Dansanda. Okay, at this point, I'll hand over to our teachers. Mark Christabel.
Hello, thank you so much. Dr. Dansanda, that was wonderful. Thank you. That was really elaborate. I appreciate you. Thank you so much. Dr. Mustafa, thank you for coming in to fine-tune something. Thank you, Dr. Mamodu. This means and every other person that contributed to Afyong and everyone that contributed. I don't know if I got all the names, but thank you. I appreciate you. Thank you so much. I don't know if our teachers, anyone has any more comments.
I can't hear you, Ma.
That's a success.
Am I the only one?
Okay.
Good morning, teachers and them, facilitators and them participants. Thank you so much, Dr. Dansanda, for this lucid presentation, and then for fine-tuning it to Dr. Sani and all the comments. I think a lot has been said about immunization, so I won't talk about it. Just to add that. The major reservoir for rabies are actually unvaccinated animals that have been listed: dogs, bats, antelopes, and what have you. In your slide, you said the incubation period, it can be up to 90 days, but some studies, articles have also reported that it can extend to up to a year. So it actually has a long incubation period. And that is why, just has been said, as much as possible, these patients should be immunized before the symptoms begin to, occur. And then to talk a little about the pathophysiology. So a dog bites and then the virus is inoculated and is also replicated in the muzzle. After that, the virus actually binds to acetylcholine receptor at the neuromuscular junction, and that's where the neurologists come in. Okay, so and from there it now travels, okay, to retrograde transport. So there's retrograde, there's according to your slide, transport. It is where this virus travels, within the axons through the peripheral nerves and then goes, to the motor neurons. Now, when the next presenter is talking about tetanus, we are going to be comparing them because they actually have some similarities. And so it begins to replicate at the motor neurons. We know that the motor neurons, what the activities are most of the time, is motor activity. And so you see that hyper activity in the patients, especially when we go to the, pathogen physiology of the furious rabies. And then it now goes to infect the brain and causes that centrifugal spread. Okay, I think that is the anterograde via anterograde transport. This is very important. Histology, most of the time, when you do histology, what is seen is in everybody's. That is also very important to note. So for the passive and active immunization you talked about, for the active immunization, okay, what is used is the VDCV, that is the human diploid cell vaccine. While for the passive, what is used is either the human rabies vaccine immunoglobulin or the equine rabies immunoglobulin. There's no treatment that has been established, as you have said, so prevention is actually the key. Just to summarize by saying that it is important that we know the stages, the clinical stages of rabies. Okay, so apart from the incubation period of 20 days or more, you have the prodromal phase and then the acute neurological phase, and then the patient can now progress to become comatose. It is more than the first 20 days or more, then the prodromal phase, I can say, lasts for another 10 days. Now, for the acute neurological stage, it is important to note agitation, hyperactivity, hydrophobia. Okay, so it can also be paralytic, where they just have flaccid paralysis and then quadriparesis, just like has been said. So we should note that in case the question comes in the other way, they must not be furious. Okay, so in paralytic, if the patient has paralytic, rabies, they will not be furious. They just become flaccid and then progresses to quadriparesis and then coma. Okay, and subsequently death if the patient is not lucky. Recovery is very rare, and so we should preach prevention. Okay, prevention is very important. Thank you. These are my add-ons.
Thank you, the success. But I had to, I don't know if your hand was up earlier. I don't know if you see how to say something.
Okay, good morning, ma. Thank you, Dr. Dankanka, for the presentation. Thank you, colleagues, for the contributions. The rabies is not that very uncommon. I just wanted to draw our attention, so we should actually get the history properly. It's not very uncommon. I could remember in the last 3 years, we're able to manage like 4 rabies cases in Kano. And all of them died within 10 days. So, and it's important for those going for exam, teacher medicine, is another aspect of the One Health that the West African College, sometimes they like to ask question on the issue of veterinary medicine, human medicine, animal health science, and all those things. So it's another area that we should pay attention to it. And like they all mentioned, the most important in the management of the patient is the prevention. And it's always better once there is a case of dog bite or this wild animals bite, it's always better you give the post-exposure prophylaxis, whether the animal is rabid or otherwise, because we are losing nothing and at the risk of giving is less than risk of not giving the vaccination. So thank you very much for the presentation.
Oh, thank you, Dr. Dahato. Thank you so much. I don't even know if our teachers have any comments. Okay, thank you. Dr. Ekele, let's move to the next presenter. Dr. Dansada, once again,
All right, thank you, Ma. Thank you, Dr. Dansada. Please don't share. Dr. Mamadou, Dr. Bimpe, please can you help us share? Dr. Musa, you have the floor. Dr. Dansada, you cannot share your slide, please. Can someone help us share the slide? It's on the group.
Okay, it's off, right?
Thank you so much, Dr. Mamadou. Dr. Musa, you can go ahead.
All right, good morning, my fellow colleagues and our teachers. I am going to be talking about tetanus as an overview in the next few minutes under the following outline. As an introduction, tetanus is an illness characterized by an acute onset of hypertonia.
Sorry.
Hello?
Sorry, a minute.
Okay.
Did I send the wrong slide?
I think you sent me the wrong slide, though.
I sent the wrong slide, sorry. Sorry, Dr. Musa.
Okay, because I'm using my system.
Please, can you send me that slide, your slide again, please?
Okay.
Please. Sorry.
I'll send it.
Okay. Dr. Musa, you're the one who sent the wrong slide. Please check the slide and send it to me. Check it again,
Really?
please.
What happened? An illness characterized by an acute onset of hypertonia, painful muscular contraction, usually of the muscles of the jaw and neck, and generalized muscle spasms without other apparent medical causes. A historical perspective of tetanus. Tetanus, a Greek word meaning to stretch. It was first described by Hippocrates and Sosruta. In 1884, Otto Nicolia isolated the strychnine-like toxins of tetanus from free-living anaerobic soil bacteria. In 1884, again, Antonia Colli and Giorgio Ronton, two pathologists of the University of Turin, demonstrated the transmissibility of tetanus for the first time. The epidemiology. Despite widespread immunization of infants and children since 1940s, tetanus still occurs, particularly in developing countries where immunization programs are very poor. Tetanus is an international health problem, as spores are ubiquitous. The disease occurs almost exclusively in persons who are unvaccinated or inadequately immunized, and even in those that are adequately immunized that fail to maintain immunity by appropriate taking of booster doses. Tetanus occurs worldwide, but is more common in hot, damp climate with soil rich in organic matter. The etiology. Tetanus is caused by Clostridium tetani, an anaerobic motile gram-positive rod that forms oval, colorless terminal spores, tennis that resemble tennis rackets or drumstick shape. It exists in sporulated and vegetative states. Tetanus spores are found throughout the environment, usually in soil, dust, and animal waste. The spores are widely distributed in the intestines and feces of many animals, such as horses, sheep, cattle, dogs, cats, rats, guinea pigs, and chicken. A significant number of human adults may harbor the organism. The spores can also be found on the surfaces and in contaminated heroin. Heroin users, particularly those that inject the drug subcutaneously, appear to be at high risk of contracting tetanus. Tetanus is acquired through contact with the environment. It is not transmitted from person to person. Route of entry. Apparently, route of entry most of the times result from apparent trivial injuries that may not need in which patients may not sought for medical attention. Animal bites, human bites, open fractures, punctured wounds such as those caused by rusty nails, splinters, or insect bites. It's also associated with burns, gangrene in neonates, usually via infected umbilical storms, and abscesses, because it can complicate chronic conditions like abscesses, gangrene. Parental drug users abuse and at times there may not be injury and the portal of entry may not be found. Tetanus-prone injury, usually wounds lasting greater than 6 hours, wound with devitalized tissue, septic wound, wound caused by blunt trauma or bite, wound contaminated by soil or manure, more common in areas where they rub animal feces after sustaining an injury. The pathogenesis of tetanus. Primary symptoms is caused by the neurotoxins tetanosplasmin, a neurotoxin produced by gram-positive obligate anaerobic bacterium Clostridium tetani. And this tetanosplasmin is a single-chain toxin that is usually produced that is cleaved into heterodimer, consisting of a heavy chain containing made up of 100 kilodalton and a light chain made of 50 kilodalton. The heavy chain usually mediates the binding of the toxins to the peripheral nerve ending and then the entry into the nerve cells, while the light chain usually inhibit the release of inhibitory neurotransmitters, the glycine and the GABA. So usually, following an injury, trivial injury, the wound is contaminated with tetanus toxins. It's contaminated with spores of the Clostridium tetani. But germination into the vegetative states and toxin production is only occur in wounds that are characterized with low oxidation reduction potential, such as wounds containing devitalized tissue, foreign body, or gangrene. And when on reaching there, the tetanus toxins, the nerve terminal, the vegetative cells multiply and produce these toxins. These toxins binds to the nerve terminal, nerve ending, and via retrograde intrarenal transport, eventually gets to the nerve cell bodies in the brainstem and the spinal cord, where they inhibit the release of inhibitory neurotransmitters, the glycine and GABA. So basically, the summary is that in the central nervous system, that's in the brain, they inhibit the release of neurotransmitters, and this continued inhibition results in the activation, in the excessive activity of the alpha motor nerve fibers that results in rigidity and subsequently spasm. Then in the spinal cord, they also affect the preganglionic sympathetic fibers. The inhibition of this results in excessive circulation of catecholamines and then excessive sympathetic activity. Tetanus toxin, tetaноsplasmin toxin also at the neuromuscular junction act like the botulinum toxins, where they inhibit the secretion of neurotransmitters, causing paralysis and weaknesses. So they act at different levels: in the spinal cord, in the brainstem, and then in the central nervous system, in the neuromuscular junction. So tetanus affects skeletal muscles, basically, a type of striated muscle used in voluntary movement. The other type of striated muscles or heart muscles cannot be tetanized because of its intrinsic electrical properties. I've just described the loss of inhibition of preganglionic sympathetic neurons leads to sympathetic hyperactivity. I've said that. So the types, we have the traumatic type, puerperal type, octogenic type following air infection, idiopathic where injury or portal of entry cannot be identified, tetanus neonatorum following poorly-treated umbilical storm. Then based on location, we have generalized, involving basically all parts of the body, localized, then cephalic. The incubation period usually varies from 1 day to several months. It is defined as the time from injury to the first symptoms, which is trismus. It is the time from first symptoms to the reflex. Then the onset period of onset is defined as the time from the first symptom, the trismus, to the first reflex spasm. An incubation period of 4 days or less, or a period of onset of less than 48 hours, is associated with the development of severe tetanus. The clinical features: this time around, generalized tetanus is the most common, and is associated with increased muscle tone and generalized spasms. Usually, median time of onset is usually 7 days after injury. And patient first notices increased tone in masseter muscles, presenting as trismus or lockjaw, followed by dysphagia, stiffness, pain in the neck, shoulder, back muscles appear concurrently or soon thereafter. Rigid abdomen and stiff proximal limb muscles. Hands, feet are relatively spared in generalized tetanus. This is picture. So, rectus sardonicus, contraction of the muscles at the angle of the mouth and frontalis. Opistostonus, spasms of extensors of the neck, back, and legs to form backward curvature. Increased muscle spasticity. Prolonged muscular action causes sudden, powerful, and painful contractions of muscle groups. These episodes can cause fractures and muscle tears. If respiratory muscle is involved, it can lead to apnea and even respiratory failure. Other symptoms include drooling, excessive sweating, fever, irritability, swallowing difficulty, uncontrolled urination or defecation. Autonomic disturbances seen in tetanus could be sustained or labile hypertension, progressive and refractory hypotension, peripheral vasoconstriction, tachycardia, episodic commonly, bradycardia and asystole, arrhythmias, fever, profuse diaphoresis, salivation, increased bronchial secretion, gastric stasis, ileus, and urinary retention. Clinical grading, ablet severity grading. Tetanus is graded into the following grades. Grade 1, mild, in which muscle rigidity affecting one or more group of muscles, sparing the muscles of deglutition. Grade 2, moderate tetanus, involving characterized by muscle rigidity involving the muscles of the muscles group. Grade 3A, severe, characterized by muscle rigidity and reflex spasms. Then grade 3B, very severe, characterized by autonomic nervous system changes added to the previous characteristics. Then the diagnosis of tetanus. Diagnosis of tetanus is made on the basis of clinical features of the disease. However, Clostridium tetani is a common contaminant of wounds and may be found even in patients who do not develop tetanus. Hence, isolation of the bacteria from a patient may not be diagnostic. There is a simple bedside test to diagnose tetanus described by Apte and Carnard, the spatula test. The posterior pharyngeal wall is touched with a spatula and a reflex spasm of the masseter indicates a positive test. It has about 94% sensitivity. Then the second bedside test is the altered whistle test developed by Eric R. Dunn. The alteration of a person's whistle in tetanus can be explained as an early effect of the increased tone in facial muscles, which causes the classic rhesus sardonicus. Principles of treatment. 1. Neutralization of the unborn toxins and circulating toxins, prevention of further toxin production, control of spasm, supportive care, active immunization, and managing complications. Neutralization of unborn toxins is usually achieved using the human tetanus immunoglobulin or anti-tetanus serum. The dose is 3,000 to 5,000 units for the tetanus, the human tetanus immunoglobulin, and anti-tetanus serum is usually 1,500 units. Prevention of further toxin production using wound debridement, usually the devitalized wounds, creating the low oxidation reduction potential. Then use antibiotics, but the choice of antibiotics varies according to experts. Either use metronidazole or penicillin, but most experts prefer the use of metronidazole because it has an excellent antimicrobial activity and it lacks the GABAergic antagonistic activity compared to penicillin. Then in those that have penicillin allergic reaction, sensitivity, other antibiotics can be used like erythromycin, clindamycin, and tetracycline. Control of spasm. Usually patients are nursed in quiet environment, preferably in the ICU. You avoid unnecessary stimuli, protect the airway. Then medication can be used. There's diazepam. Generally, the benzodiazepine are regarded as the first line, like diazepam. Then the others like the barbiturate and the clopramazine considered as second line drugs. And even in severe cases, magnesium sulfate can also be used, and even baclofen, dantrolene, vicuronium, pancuronium can also be used. Then supportive care, adequate hydration, nutrition. Usually it's nil per hours because of the stasis and then the paralytic ileus. Seriously ill patient may be fed using NG tube or gastrostomy, parenteral elimination. Okay, treatment of secondary infection, then prevention of bed sores. Then active immunization. Tetanus does not confer immunity against subsequent infection. So preferably tetanus toxins are usually given 3 doses. First and second doses usually between 4 to 8 weeks apart, and the third dose usually within 6 to 12 months later. Then the complication of tetanus, briefly, we have airway, aspiration, laryngospasm, sedation, association, obstruction, respiratory system, we have apnea, respiratory failure, acute respiratory distress syndrome, then cardiovascular, tachycardia, hypertension, ischemia, hypomia, asystole, cardiac failure. Renal, have renal failure, urinary infection, gastrointestinal stasis, ileus, miscellaneous, weight loss, thromboembolism, sepsis, multi-organ dysfunction syndrome, fracture due to spasm, muscle rupture. Then the differential diagnoses are many, but however, these are the ones I listed: strychnine poisoning, alveolar dental infection like the alveolar abscess, local infections, hysteria, encephalitis, dystonic drug reactions, hypocalcemic tetanus. However, what differentiates this from tetanus is that in tetanus, they usually have markedly increased tone in the central muscles involving the face, neck, chest, back, and abdomen, with superimposed generalized spasm and relative sparing of the hands and feet. When you find this, then tetanus is highly suggestive. Prevention, usually tetanus is completely prevented by active immunization. But however, immunization provides protection for just 10 years. Clinical tetanus does not produce immunity to further attacks. Therefore, even after recovery, patient must receive a full course of tetanus toxoid. That's the tetanus toxoid, 3 doses, then with booster doses after every 10 years. In conclusion, tetanus is a major cause of mortality, particularly in developing countries. Sedative, diazepam is the mainstay of treatment. Tetanus is completely preventable by active tetanus immunization. A death from tetanus is a preventable death. Thank you.
Okay, thank you so much for your presentation. That was a beautiful one. Okay, I have a question for you. Just one. Okay, I actually realized comparing the two topics that have been taught today, that's tetanus and then rabies. Looking at the pathophysiology, I realized that there's lots of inhibitory actions or inhibitory activities. Okay, like for example, we have the inhibitory neurotransmitters, which are the glycine and the GABA. So I realized that both in the tetanus and the rabies, it actually inhibits the glycine and the GABA, thereby causing that excitatory effect. So I want to know, is there any other extra thing to like distinguish between tetanus and rabies? Because I know the common thing they have is that there's loss of inhibitory activity where it suppresses the glycine and GABA. Is there any other additional thing in the pathophysiology of this tetanus you just talked about? Thank you.
I have not taken time to bring those out, but let's look at it together. In tetanus, just as I have said, usually there's marked increase in muscle tone affecting the facial muscles, the central muscles, that's the facial muscles, then the neck, the chest, abdomen, and the back. Then with generalized spasms, sparing the hands and feet. But I don't know in tetanus, I cannot remember vividly even in tetanus, in rabies, that spasm, they have that spasm. And in tetanus, usually, this retrograde transport of toxins responsible for most of these symptoms is the same for all the nerves. So therefore, shorter nerves are affected earlier. That's why you have facial involvement before the trunk and the limbs. So I don't know that in tetanus. And then one thing about rabies, they classically have this hydrophobia, which is not very prominent in the tetanus. And I think these are the things I can remember based on the pathophysiology, because I've not read, honestly, I've not taken time to look at rabies in details.
Okay, for the tetanus you talked about, is it anterograde? Because I know for rabies,
in tetanus, just as I have said, is retrograde, because when these spores germinate into the vegetative forms and produce the tetanus plasmids, they bind to the peripheral motor end terminal. So from there, they enter the axons and move retrogradely through the axons to the cell bodies in the spinal cord and in the brainstem. So in the spinal cord there, in the brainstem there, they inhibit the release of neurotransmitters, specifically the light chain of the tetanus plasmid that cleaves the synaptobrevin, which is an apparatus that is essential for the synaptic release function. Then in the spinal cord, they also cause inhibition of release of inhibitory neurotransmitter, thereby allowing the preganglionic sympathetic fibers to act without inhibition, resulting in increased circulating catecholamines and the sympathetic hyperactivity. So it's retrograde. Then also in the neuromuscular junction, they act just like the botulinum toxins, where they inhibit the release of neurotransmitter, resulting in paralysis. So this is their own mode of action. And some of them, another way they can be disseminated is through the blood-brain barrier, through the lymphatics and then the blood, resulting in generalized tetanus. But however, they do not enter the central nervous system because the blood-brain barrier prevents that.
Okay, thank you. Thank you so much. Okay, Dr. Kele's network is a bit epileptic, so I'm going to step in for her. Okay, so going into the chat room, Dr. Blessing Azukwe is saying thank you for the wonderful presentation. Dr. Abimbola is saying thank you for an excellent presentation. Dr. Momodo, Dr. Becky Obasi, all of them are saying thank you for your presentation. Then Dr. Momodo is asking, please, can you distinguish between strychnine poisoning and tetanus? Strychnine poisoning and tetanus, can you differentiate between two of them?
Well, the strychnine poisoning basically there will be a positive history of exposure to pesticides. So historically, there will be that history of exposure. While in tetanus, in most cases, there will be history of trivial injury, except in rare cases whereby the portal of entry is not available. It's not the portal of entry or the site of the history of injury may not be identified. Just as I said earlier on, that usually most of these things are acquired through trivial injuries that may make the patient in which the patient may not sought for medical attention. Then that's one. Then that prominence of central muscle hypotonia would superimpose spasms, differentiate that from that of strychnine. And in strychnine poisoning, most of what is organophosphate, mostly you have the parasympathetic activity, exaggerated parasympathetic activities. So this is what I can say about that.
Okay, thank you so much.
Important. History is very, very important.
Okay, thank you so much. Okay, thank you so much for your response. Okay, I'm not seeing any more chats on the chat room, and I'm not seeing any electronic hands up. So I want to thank you once more for an excellent presentation. Good job, well done. So in the absence of further questions and contributions from the participants, I want to please hand over the class to Chief Christabel. Thank you.
Thank you so much. Dr. Kalamama, can I be heard?
Yes, very much. You can be heard very much.
Okay, thank you. So, Dr. Musa, thank you so much. Thank you. I appreciate the presentation. Thank you. That was quite wonderful. I appreciate all that contributed on Mamudu again. Thank you. I don't know if I got all the needs of everyone that have contributed, but we appreciate your contributions. Thank you so much. I don't know if any of our teachers have any comments past 8. Any comments from our teachers? Dr. Success, go ahead, please.
Okay, good morning. Just to comment, thank you so much, Dr. Musa, and then make some melody. To melodify some things. Okay, so first of all, yes, so tetanus can actually occur without puncture injury, or maybe any history of neonatal issues on those stuff. In like 10 to 20% of patients, it can occur. Musa, please, you might need to correct it in your slide. Incubation period is 3 to 21 days in most patients. So these are some of the differences between the rabies we talked about and then tetanus. Okay, although in some patients, rarely in some patients, it may get up to a month, but most of the time, incubation periods for tetanus is 3 to 21 days. The scoring system is very important. Apart from ABLET, the other severity scoring system. And it's important to note too that for prognosis, for prognostic, one of the very important prognostic scoring system is DACA. Please add it to your slides. It's very important. We also see that because it's one of the things that they may also want us to know. Now, tetanus is a very, very, very severe illness of the body, and then mortality can be up to 60%. I just want to talk about the pathophysiology. Florence, but tracing on your question. Now, if you look at the pathogenesis or pathophysiology of rabies and then tetanus, they are seemingly not really the same. Okay, so what happens in tetanus is that, okay, so there's inoculation of this spore, and then, it releases toxins. For tetanus, there are 2 important toxins that it releases: the tetanolysin and then the tetanospasmin. We have not yet known the significance of the lysine. However, in the pathogenesis of tetanus, is the tetanus plasmin, that is the neurotoxin that carry out all the pathophysiologic processes that are seen. And of course, this is not seen in rabies. Now, what does this neurotoxin do? It actually goes, it travels and then goes to the anterior horn of the spinal cord, where we have the motor neurons. Okay, and when it goes there, one of the things it does is that it causes inhibition of the GABA, presynaptic inhibitory interneuron terminal. Okay, and this is called synaptoprevin. For neurologists, I think we might need to know this. Okay, and this is the molecule that actually causes the release of the neurotransmitter GABA. Now, when it acts on this molecule, what does it do? It now causes inhibition of GABA. We know that GABA is causes inhibition. So if you inhibit inhibition, the product will be excitation. Okay, so that is what we see. And then there's other pathophysiologic mechanism he talked about, where there is causing autonomic nervous system disturbance. Now, this is what happens in patients that have tetanus. Talking briefly about the management of patients with tetanus, there's this acronym I usually use, and it is NECS, N-E-C-S. Okay, so this is important. So NECS. So if you see a patient with tetanus and comes to you, what do you do? Of course, apart from the ABC of resuscitation, N is you want to neutralize the unbound toxin, which is very important. So how do you do that? We give the tetanus immunoglobulin, and then we also want to eliminate the organism by giving of course, what we are dealing with is the unbound toxin, because we know that for the toxins that are bound, it is irreversible. Okay, and then we also want to give them antibiotics, metronidazole, and he has talked of why we should avoid penicillins. The next one, which is E, is elimination of the organism. Okay, so this is important. We do that by giving the antibiotics. The C is control spasms, which we must do for every patient that have tetanus. We have to control the spasms. So most of the time, we want to put diazepam in a normal saline to run for 4 to 6 hours, and then we continue the process and see how we can actually control the spasms. If it does not suffice, we can even go ahead and give magnesium sulfate, and then other the others he has also talked about. And then supportive therapy. Supportive therapy, very important. You want to nurse this patient in a dark room, in a quiet room, NG-tube feeding. You want to maintain, the glycemic control of this patient, because, because of the excessive, because of these spasms, they are prone to having hypoglycemia. So you want to manage bladder, and then bowel care, very important. You want to turn this your patient regularly so that the patient doesn't develop sore. Then for patients, of course, these patients, you have talked of why they have autonomic dysfunction. We need to manage appropriately. So if they have bradycardia, we might need to give atropine. They may also need nootropic support. So it's important to know that prevention. It is very important we prevent, and then also massive immunization for those that have open wounds. And then the prognostic indices we must know for patients that have tetanus in case it comes out. What is the poor prognosis? What are those prognostic features? Estimates of age, of course, presence of comorbidities. How proximal is it to how close is it to the CNS? What do I mean? So if a patient has a wound in the hand and the wound close to the neck, we know that of the neck will portend a poorer prognosis. And then short, just like he said, short incubation period, like I just explained, and then a patient that has fever. Now, talking about the prevalence of tetanus, even in Nigeria, the prevalence actually varies. I was trying to do a study in tetanus. Well, I wanted to look at the prevalence of tetanus in South Nigeria and then in Southwest Nigeria. Okay, so we discovered that people in the Southeast actually have a lower prevalence compared to those in Southwest Nigeria. So we're actually looking at that study, and then hopefully we'll also see how far we can go with it. So these are my small comments on tetanus. Thank you, Musa. Thank you. Well done. Very well done.
Thank you.
Thank you so much for success. Thank you. I appreciate the contribution. Thank you so much. I don't know if any other comments. We need to close the class. Dr. Success, thank you. Dr. Musa, that was